But I think, there's going to be other lymphomas that I think this is going to have an impact.
Yeah, and so I was going to say, right now we're talking about finding a potentially curative regimen for people who failed a therapy that was potentially going to cure their lymphoma, but there are a lot of lymphomas that we don't have conventional cures for. When we get to the second and third line treatments for those lymphomas, even though they have generally longer natural histories, response durations are short and people relapse, and we start to see decreased life expectancy. And so I think what we've already seen for mantle cell lymphoma, knowing that patients who relapse after BTK inhibitors have a very, very short overall survival on the order of months, has been very impressive. And I think we'll talk today about some of the data that was presented in indolent lymphomas as well, especially in the late lines of therapy.
We certainly will. And a lot of that will be your data. And I think it's very, very important data. Indolent lymphomas, people are less impressed. Oh, they have an indolent lymphoma. Well, there is this business of progression of disease within 2 years. As a subset, maybe 20% or so of patients that have a bad indolent lymphoma. But having been in practice now for, I hate to admit it publicly, but 40 years, okay? I'm actually older than I look, okay? And I'll say that when you've taken care of these patients for 10 to 15 years and they've been through a number of treatments, guess what? They're not progressing within 2 years, but you know what? It's a bad disease. And Karen's right. We need something for those patients too. It's just not captured quite the same way because we're looking at patients, with much shorter follow-up. But yeah, at the other end of the indolent lymphoma natural history, it gets bad. Okay.
And finally, Steve, I'd say, it's important to remind the audience, we're the gateway drug, right? We're the gateway drug to cellular immune therapies for the non-blood cancers, for the diseases that need alternative therapies beyond chemo. The lessons we learn in lymphoma, leukemia, mantle cell, and myeloma, like everything that's ever happened in hematology, will be important guides for how do you combine therapies, how do you target, and we're the gateway drug. I like that.
No, you're exactly right. Rituximab taught us that patients can respond to immunotherapy when they're resistant to chemotherapy. So you hit an external target with immunotherapy and you can get a response in a disease that is resistant to all kinds of toxins that kill cells by getting into them. We saw that with Rituxan, but then there were Rituxan failures or Rituxan chemotherapy. Now we're at the cellular end of immunotherapy as opposed to serotherapy, and we're seeing the same thing again. Patients that are resistant to those drugs that kill cells internally, like chemotherapy, small molecules, can respond to immunotherapy, and those that are responsive, that are unresponsive to those intracellular agents, and let's say rituximab or anti-CD20s, you can get at them with a T cell based therapy, another extracellular agent. So
what we were trying to do with GVL and allogeneic transplant to a much larger degree with a much shorter period of toxicity and less toxicities. So, it's less of a bazooka approach of an allogeneic transplant and much more targeted.
Yeah. So what do you think? Is allo going to disappear, Matt?
I think it depends on the disease, depends on the context, and depends on who you talk to. But, there are going to be subset of patients once we actually can risk stratify. And I think there are going to be various, whether it be clinical characteristics or drug characteristics or product characteristics in terms of persistence, and what may be important for one disease in terms of persistence may not be the same for another. And so depending on what we see and how we risk stratify, I could see a world where, just like we have a low risk AML and you can cure that with consolidation therapy, you could have a low risk lymphoma or leukemia that you don't need a transplant for, but others you may want to transplant, say, at 3 to 6 months. Who knows?
There's an important point to make here, though, and that is that the lymphocytes that give rise to lymphoma are long-lived cells, and they're far beyond the hematopoietic stem cell stage, sometimes lifetimes worth. Whereas the cell which is contributing to AML, MDS, myeloproliferative disorders, that's about 14 days down the pipeline. And so we are continually going to be facing the problem that the patient not only needs a cellular therapy, Steve, for AML or myeloproliferative disorder, but it's going to need a lot of repair of a very damaged genome.
Yeah. So my answer to my own question would have been, Well, first of all, I'll say Loretta's going to tell us about allo CAR. So there's always going to be allo if you believe in CARs, number one. Number two is what we're talking about today is what David just said. We're not addressing stem cell diseases. We're taking care of neoplasms of mature cells. So there always will be diseases where we have to replace stem cells. And right now, the only way I can think of is CAR, but I'm sure with the way technology is moving, we'll be de-differentiating our skin cells or something soon and making our, I don't know. But you're going to need different stem cells, not your own, for certain diseases. It's never going to disappear, okay, in my opinion. And you know that I believe very much in CAR T-cell therapy. But I think that, you never want to throw the baby out with the bathwater. We'll hold on.